Hi, Dr. Lustberg. Thank you so much for joining me today. I just want to ask you why you are part of Learn, Look, Locate and what you'd like to do with Learn, Look, Locate as part of your outreach to patients and helping.
Thank you, Cynthia, for having me. I'm Maryam Lustberg. I'm a breast medical oncologist and chief of breast oncology at Yale Cancer Center. I wanted to join Learn, Look, and Locate because I really believe in your vision to improve access to evidence-based education and really provide the latest information to individuals living with breast cancer so that they can make the best decisions for themselves.
Your work is very patient focused. Can you tell us a little bit more about that as far as the partnership and decision making and what you think is, your how you work and what you think is needs to be done more as far as physicians working with the newly diagnosed?
So obviously the diagnosis of breast cancer or any cancer can be extremely overwhelming. And I do see myself as a guide to provide the latest information and to really help with the decision making. But ultimately, it really does come down to the patient and what he or she wants for their care. And so that's the principle that I try to bring into every visit and really present all the choices and options so that shared decision making can take place.
Do you think that the newly diagnosed have the opportunity to process the information that is coming at them when you're explaining the diagnosis?
You're absolutely right in that those initial days and moments when you're hit with the diagnosis of cancer can just be so overwhelming. And part of that is some difficulty processing. So yes, so I do see over and over again that maybe the information that I have initially shared is not quite processed. But that's why there should be opportunities to do additional visits or additional communications after those initial consultation and to not rush into decisions because there can be a lot to take in and it's all right to take your time.
How can we, as a survivor myself who felt completely overwhelmed with my 1 hour appointment to digest all of it, surgery, diagnosis, size of tumor, and what I didn't know the size of tumor till afterwards. How can physicians make this? That's why these interviews are so important, the accessibility to your knowledge. We are starving for this. So many of us have been diagnosed and we need you and we're thirsty to digest this. How can oncologists and breast surgeons really help with this? It's really bridging that gap.
Yeah, it's a wonderful question. It's absolutely a problem. I don't think we get it right at every visit. I think it's important to admit that. I think it's helpful to take pauses during visits like this and ask for questions longitudinally along the way instead of just at the end. So typically, if, for example, if I'm explaining the pathology report, then I pause and ask for questions at that point. Then I move on to the treatment options. Having somebody with you in the visit is absolutely helpful so they can be taking notes. Recording sessions can also be helpful. And then I think a lot of questions actually surface after the visit and making sure that you know how to reach your healthcare team so that additional discussions can be had.
Do you think the average woman really truly understands HER2 negative, HER2 positive, ER negative, ER positive, triple negative, triple positive, all of these terms?
So I do think every patient is a little different. So I really want to respect individual differences across patients and that they come to the diagnosis with heterogeneous backgrounds, heterogeneous knowledge bases. So I do think it's variable. But I think if I had to say the average patient, I think there's more confusion than not, because as a healthcare team, perhaps we're not sharing the information in ways that we should, or maybe there is understanding initially, but as time passes, things can become blurry.
Do you think the medical community really understands the emotional impact that is coming at someone newly diagnosed all at once with the terminology, the treatment plan? I personally feel like it was a somewhat of a car wash, that the emotions were just left in the back seat.
I think we absolutely can do a better job as a healthcare community in terms of addressing the emotional aspects of the diagnosis. I do firmly believe that. I had a breast biopsy myself a few years ago, and I think even though I had practiced breast oncology for over a decade, I don't think I quite appreciated just what it would feel like to go through the medicality of the procedure and then waiting for results and the anxiety associated with that. So I think some of it we absolutely can be more sensitive. I think the other part of it is that until you have experienced something yourself, it's very difficult to fully understand the emotional spectrum of going through something as traumatic as a cancer diagnosis.
Yeah, I would say the waiting. Can you talk about the waiting for the results and what your thoughts are on that?
The waiting, from what I've heard from many patients, can be excruciatingly difficult. There have been instances where, part of the access to your results in some ways has made it a little bit easier, where patients are sometimes release those results as soon as they do become available. However, even that can be a mixed bag for some patients, because they may be for the first time seeing the diagnosis of cancer or a diagnosis of an abnormality before they've had a chance to speak to a healthcare team. But certainly the waiting is very, very anxiety producing.
Big focus of your work is helping to manage side effects. And I think that is really important, because I myself developed a severe skin allergy after radiation. And so, the immune system and everything that could happen. And through my work at Learn, Look, Locate, I've learned that there are ways to somewhat get ahead of lymphedema and possibly neuropathy. Can you talk about that?
Yes, so I think one of the shortcomings of a lot of medical care is that we focus so much on the medication and the drugs and the treatment that we spend much less time talking about ways to mitigate toxicities from our treatment. So all of the things that you have mentioned, whether it be neuropathy reactions, we don't have perfect solutions for them, but we certainly do have some strategies to help reduce the impact, so that cancer survivors are not left with long-lasting toxicities that they're battling with for the rest of their life.
So when I reflect on my diagnosis, and now a couple years later, the list of what we need to digest to get ahead of, understand, even down to reconstruction, is very lengthy. It's a small window of time. And so it's really important that we educate. Don't you agree?
I agree. I think, the patients who I see come in with their notebooks, who've done their research, who come with a friend or a partner with them to these visits, I see how much more information they have when they actually leave the visit. And then in contrast, I've seen patients who come alone and they sort of leave it to us to kind of tell them what to do. And I don't think that's the best care model at all.
Interesting. What would you say about what's going on in the rise of young women and breast cancer? Because I see it on social media and it is unbelievable what's going on. So I'm going to start with that.
So there There has been a slight rise in younger breast cancer, breast cancer that's diagnosed before the age of 40, and it has multiple factors, including, if we look at the last several decades of our culture and our lifestyles, there have been a lot of changes in terms of our diets and uh, activity levels. We've become a much more sedentary society. Obesity is on the rise. Having said all this, in no way am I blaming any younger person for their cancer. It's not about that. But I think as a society, our exposures, our lifestyles have definitely changed. And I think that is probably part of the slight increase that we're seeing. It's important to look at the data very closely because depending on how it's presented, it may seem like a bigger increase than it actually is. It is there, but I think it's a small trend upward, yes.
So with that being said, in my work with Learn, Look, Locate, I have met so many young women who have been dismissed, misdiagnosed, and I am going to do everything I can to work with the medical community to help stop this, because I have a huge passion for helping to raise awareness for Paget's disease, inflammatory breast cancer, lobular, the sneaky ones that do not show up as a tumor. So can we talk about that from your perspective?
So thank you for all your advocacy. You're absolutely right that younger women who are at risk for breast cancer or who may be diagnosed with breast cancer are actually have a much harder time accessing care services because the bias and the assumption is that, well, this is not a cancer that younger women get, which is truly false. Part of the difficulty is that also younger breasts tend to be more dense. So it would be, it's not uncommon for imaging to miss certain cancers, particularly like you mentioned, lobular cancers, which can be very diffuse in appearance and it can be very hard to show up in certain imaging tests. I think the best advocacy that we can all do is really empower younger women to not ignore changes in their breasts. And if something feels different, really keep pushing and not allow themselves to be ignored by just, oh, that's a cyst, don't worry about it. Really, any breast abnormality has to be fully evaluated no matter how young you are. And then we are continuing to do research in terms of how to better understand younger breast cancer, what are the different genetic and clinical characteristics so that we can better risk stratify, so that it's not a one-size-fits-all approach of you're an average woman, you get mammograms at age 40, but there are definitely certain individuals who actually need much closer breast surveillance based on their risk, and they may need to start much sooner. So I think the idea of personalized screening and personalized medicine applies as much to breast screening as anything else. And this is what the field is really moving toward. This is what we're researching.
Yeah, I think the hardest part that I see on social media is because young women do not get access to any type of screening, the fact that they're finding their cancers themselves is truly a miracle, because I never did a self breast exam and got normal mammograms and had a walnut-sized tumor. So
I'm part of the CDC Young Breast Cancer Committee, and one of the things that we're actually looking at is that, breast education and breast health awareness has actually fallen off the radar in many societies and in many clinical exposures that these young women have. So we're actually not teaching what to look for and how to do a breast exam. And so this is something that really needs to be looked at because it's particularly relevant to younger women who are not getting the standard imaging studies because
that's wonderful.
guidelines are.
Good information. We need to get this out there because one thing, working with all of you, the Learn, Look, Locate medical advisors, there are a lot of great advances being made, but we don't know about them. And I want to
Yes.
get this out off the press so that people are aware
Yes.
that there's a lot of good work.
So what changed was, a few years ago, there was a randomized study called the Shanghai study, which was done in Asia. And what it showed was that self-breast exams did not change mortality. But in many ways, it was a flawed study and it didn't take into account many different risk factors. And so what happened is after that study, essentially breast awareness and breast health education essentially fell off the public health radar. And I think it has had many downstream effects, unfortunately, that we're trying to reverse.
Yeah. I mean, specifically inflammatory, I have some dear survivors that I work with that really, if it
Yes,
weren't for, timing, I mean, this is an aggressive one that is just,
exactly. And most patients with inflammatory breast cancer may report that, they've gone a period of time where they've been treated with a series of antibiotics, with the assumption that the redness and the skin changes are a skin infection and not actually a cancer. So many large cancer centers are really investing in having that multimodality inflammatory breast cancer type clinic, because these patients need to get in quickly and have the best multidisciplinary care. That's really essential for best outcomes.
from my understanding, when you are diagnosed with inflammatory, it can be like right out of the gate, stage 3. Is that correct?
Yes, that's part of the criteria. Yep.
So let's talk about the transgender community and the LGBTQ, if I'm saying it correctly. Why? Can you tell me first of all your overarching thoughts on this group of people that are getting diagnosis and the difficulty it is to treat them, or the diagnosis, that the guidelines. It seems that there's a lot of confusion around this. I interviewed a transgender man and learned a lot about what's going on and kind of how the treatment in the healthcare industry is not good. So your thoughts on this? It's kind of a lot here.
Sure. I think there is a lot of system bias that can make it difficult for various vulnerable populations to actually access healthcare. So one of the largest surveys of individuals who self-identify as LGBTQ really showed that they had less screening for cancer. They were certainly reporting biases in terms of accessing different healthcare facilities. So first, feeling comfortable in terms of feeling safe, feeling that you can actually go to a healthcare provider and that optimal recommendations are shared with you. I think that's one piece of it. Second is simply knowledge base in terms of just how do we take guidelines that are essentially heteronormative, and they were studied in heteronormative populations, and how do we really kind of use what we know to make evidence-based recommendations so that the correct screening guidelines, for example, are done for transgender individuals, etc. I think a lot more work needs to be done, and even how we refer to a breast exam. Is it really a chest exam? So the even terminology and how what we say matters. And I think all of this can impact kind of these overall health outcomes and screening utilizations.
Do you think the impact of for this community with taking hormone supplements are making breast cancer diagnosis higher? Is there an effect on this?
So the use of hormone replacement therapy is a highly individual and personal choice. And I think it's something that I think this is where shared decision making comes in, and it's so much a part of personhood and identity for a population that is considering taking it. So I think it's all about a balance of looking at kind of the importance in terms of self-identity and self-expression versus kind of potentially a small risk of cancer. And I think a good discussion on the pros and cons is typically how I would approach it.
Is there an increase in breast cancer with the transgender community?
So we do see slightly increased breast cancer rates being reported in this population, and I think it's something that we need to be aware of and kind of be able to use our best epidemiological data to make accurate risk assessments and really inform our patients in terms of and our clinicians, so that they're aware of ways to screen for chest and breast cancer in this particular population, importance of physical examinations for abnormalities. I think all of those. I do think a lot of the gaps are related to, one, awareness, and two, certainly some elements of bias and discrimination. And I think these are surmountable. And I think pages like this, conversations like this, are really part of those initial steps to move the needle.
I do want to ask you about a man who's transitioning to a woman who might be diagnosed and then taking the hormonal supplements. I'm not sure if I'm asking this correctly, but you know where I'm going.
Yeah, so I mean, this really comes back to that intersection of emotions and identity, as well as kind of the medicality of, like, let's say, you know, depending on the type of breast cancer, is it hormonally driven or not hormonally driven? I think it becomes a dialogue. I think the strict answer would be, let's cut off the hormones, because this is what was part of what's driving this cancer. I think it's so much more nuanced than that, depending on kind of how this individual is feeling about their identity and what they want to do with it. So I think this is what hour-long consultations really would entail, because it's not as simple as, well, you got to stop. I think so many factors go into it, but I think the strict oncology recommendation, whether you're a man or a woman or non-binary, is anybody on hormones with hormone receptor positive breast cancer, is that we do try to cut off those the fuel that is potentially contributing.
Do you find that this particular community, that the cancer diagnosis are late because they are not tending to, particularly whether it be screening or checkups, or just not thinking it can happen?
There's concern about that. I think we don't have the best formulated data resources and you know, evidence-based randomized studies to comment definitively on that, but yes, absolutely, anecdotally, that's possible for sure.
I'd like to ask you, if you were to speak to anyone who's newly diagnosed right now, literally just hearing the words, they got the biopsy back, and that you're telling them that they have breast cancer, what would you like to say to that person?
I think I want them to know that there are absolutely lots of resources available, and they're not always in their doctor's office. and to be an advocate for themselves, take their time, and to really hear different perspectives, look at resources, and ask as many questions till they feel comfortable with the plan of care.
And from the emotional side?
There's lots of help. The emotions are real. Obviously, they can be a lot to process, and it can be frightening. And what I can say is to normalize that experience and say that this is those initial days of a diagnosis. Many patients have told me are actually the toughest. They're even tougher than going through treatment. So really validating that it can feel terrifying, and that it will get better. But to be able to ask for support, and support will look different for different patients depending on their family or their needs or support systems. But whatever it looks like, I think there are ways to get additional support so you're not doing this all by yourself.
And the last thought is the advances being made with breast cancer, because I'm just fascinated behind the scenes with talking to all of the medical advisors and specific companies that have so much to offer. It's really come a long way, and I just loved your thoughts on that.
Yes, so there has been a tremendous amount of progress in breast cancer through dedicated clinical trials and investments and philanthropy. So it's really not been one body that has contributed to this. It's really been a very much a concerted effort from multiple circles to address one of the most common cancers that we have. So in many ways, breast cancer is often seen as being ahead of the curve in terms of whether it be from screening or risk reduction or treatments for all stages of disease. Specialists in other cancers often look to us in terms of, gosh, this breast cancer community has done a lot. So I do feel very excited in terms of advances that have been made from, for example, even looking at minimal residual disease through blood-based monitoring, for example, or having more targeted cancer treatments that may be more effective and have less toxicities. So all these are absolutely great news. I think what has lagged behind, though, is kind of what your questions have been referring to is kind of how well as a community do we really address the psychosocial aspects of cancer care, and how are we really supporting our patients. I think the focus has a lot been on this higher tech, like what's the new treatment, what is the new test. But I feel like, at least in my opinion, the experience of undergoing breast cancer treatment, I think still needs a lot more. And so I think this is where perhaps all of this cannot be done just in a doctor's office, and we need additional venues that are addressing various unmet needs that I know my patients have.
And you just saying that is one of the reasons why I started this, because I see a huge void. There's something, in my opinion, very wrong and disconnected. And so the honor of working with you and all the Learn, Look, Locate medical advisors, that you recognize this, and the validation of seeing this really empty hole, this void, this emotional trauma, and the need to calm us down, connect us, and bring this together in a way that we can be empowered, educated, but inspired and connected to you. So to be able to sit in bed and watch this interview, who's ever watching right now, and be get the information and understanding from Dr. Lustberg, who's been recognized as one of the top 27 oncologists in the nation, is just incredible. So many of you have participated in these interviews to help us feel that you understand us and that we can get through this, and that the work that you're doing also needs to be recognized, celebrated by the patients. So it is a beautiful intermingling, I'd like to say, that is very much needed. And so with that, I'm honored and thank you. So really, really appreciate it. Any last thoughts, Dr. Lustberg?
No, thank you, Cynthia. I think your passion to improve how care is delivered and how patients are actually empowered and educated on their breast cancer. I think thank you for all that you do.